Okay, today we have Dr. Vivien Bonert from Cedars-Sinai. I have known Dr. Bonert actually for years. I met her years ago at a medical meeting, and she has been such a huge proponent for acromegaly patients. She does clinical trials for acromegaly patients. She's on our board of directors for acromegaly community. She is just a wonderful proponent for acromegaly patients and has a great understanding regarding this condition. Once again, Dr. Bonert will do questions at the end. I also need to let everyone know that this program is made possible in part by a grant provided by the Pfizer Foundation. Acromegaly community wishes to thank all that have made education by the experts possible. For this, we say thank you. And Dr. Bonert, I'm going to hand it over to you, and thank you.
Thank you, Jill.
For being here today.
Thank you so much. Good afternoon, everyone. I'm really happy to have this great opportunity to share with you some thoughts on medical therapy for acromegaly. As Jill mentioned, this is a subject very close to my heart. I've worked in this field for close to 30 years. We've done a lot of research in the space, and we've been involved in all the clinical trials for the new therapies as they've come to market. So it's absolutely impossible to even cover everything, even cursorily, in an hour. But I've kind of given an overview, which I hope will be palatable to all comers in this forum, which kind of overviews the field at this point, focuses on some specific issues which are emerging, namely quality of life. So I am finding more and more that that's an issue that really is coming to the fore and probably needs a lot more attention than we've paid to it in the past. And then I'm going to end up with, before we end, we'll go over the latest developments in the field and the newest therapy that's just been FDA approved. And then we'll end up with some of the pipeline medications to show you what's down the turnpike. So I'm going to jump right in now. And, oh dear, Jill, I'm not sure why we are not. Oh, there we go. Okay, there we go. So just by way of introduction, the pituitary gland is actually the master gland. And as you can see, it really produces several hormones which are associated with a whole variety of different physiological functions. It controls reproduction, lactation, the response to stress, water metabolism, the generation of energy and maintenance of energy. Don't know. Sorry, we're gonna just.
Can you click twice?
Yeah, I don't know. There we go. As we were saying, all these different physiological functions, and of course important today is the production of growth hormone by the pituitary, which is involved in elongation of long bone, muscle integrity, and many different metabolic functions. So let's just, by way of introduction, discuss what actually causes acromegaly. And I'm sure everybody here is aware that acromegaly is caused by a benign, non-cancerous tumor of the pituitary gland, which, because it's in a gland that makes hormone, growth hormone, results in excessive growth hormone secretion, which then floods the body and has all the physiological and pathological effects, which we're going to talk about. Oh gosh. Don't know. So what what are the signs of symptoms of excess growth hormone? And they're clearly different when the pituitary gland becomes tumorous in childhood, before people have completed their growth, when the syndrome of gigantism becomes evident. So here you can see this extremely tall person who is trying very hard to catch up with this man who's on an enormous 12-foot step ladder. And when acromegaly occurs in adulthood, after growth of long bones is complete and people have attained their final heights, the effect of growth hormone on bones affects certain areas which are still sensitive to the effect of growth hormone. And those areas are largely the bones of the face, the bones of the hands, and the bones of the feet. And the gent in the bottom of this picture shows the classic physical features of acromegaly. So the lower jaw is still sensitive to growth hormone after people have attained final height. And this person has typical features of an enlarged lower jaw, prominence of the ridge below the eyes, and you can see this is called the submandibular ridge, a prominent forehead. In addition, puffiness of his lips and puffiness of his nose. So just to summarize the clinical features, those slides showed the acral changes. Acral means extremities. And by that we mean the changes in the face, which we've reviewed, the changes in hands and feet, which we're going to look at in the next few slides. And in addition to the acral enlargement, there are effects on the heart, hypertension and enlargement of the heart. There are respiratory effects, sleep apnea. There are effects on the muscles and skeleton, joint aches and pains, as well as frank arthritis. There are metabolic effects, diabetes mellitus, gastrointestinal effects, which include mainly polyps. Patients get large enlargement of their whole intestine, but the factor which we're really need to be diligent about following is the incidence of intestinal polyps, which can be premalignant. So patients should be cautious to have colonoscopies frequently and have the polyps removed before there's any untoward growth in their behavior. And then in terms of the skin, there is some darkening of the skin. You can actually see that in this patient. There's oiliness of the skin and thickening of the skin, and then there are little skin tags, which are common, especially in the axilla and the creases of the neck. So we've mentioned enlargement of the hands, enlargement of the feet. Patients get widening of their feet, more than actual increase in the length of the feet. They also get enlargement of their tongues, which, as you can see, can shrink substantially in this person with the right therapy. The lower slide here shows another consequence of enlargement of the lower jaw, where initially patients get separation of their lower teeth, and then they get an overbite, all of which can be corrected with maxillofacial surgery. But really our goals are to make earlier diagnoses and to attain tight treatment, and we're going to discuss that today, in order to really prevent these slow, insidious developments. So as we've discussed, growth hormone regulates the physical growth of the body, and it really works by a messenger called IGF-1, which is another hormone made in the liver. And this diagram shows how growth hormone from the pituitary travels to the liver and stimulates the liver to make the IGF-1, which is the hormone which really is responsible for elongation of the long bones in childhood and for the changes in the facial bones and hands and feet, which is typical in adulthood. In addition, growth hormone itself does have effects on different tissues in the body, muscle growth, growth of the heart, and the soft tissue changes often can be fully reversed with normalization of growth hormone. So it really is our responsibility to develop and administer strong therapies that firstly intercede before these symptoms and signs become chronic and irreversible. And then the important thing about the therapy is to institute it as early as possible, which is dependent on the time of diagnosis. And then once one has attained a diagnosis, to work very diligently to totally normalize the IGF-1. So above normal IGF-1s, even though they're lower than the starting IGF-1s, don't quite cut it in terms of preventing the development of symptoms and signs that become chronic. And I'm going to show you over the next couple of slides how we really have worked hard to develop really remarkable tools, which I do believe in 2020 are able to control almost 100% of patients used correctly and titrated appropriately. So the treatments that we have in our toolbox to control acromegaly are initially transsphenoidal surgery. So debulking surgery is really recommended and instituted in most of the patients. Unfortunately, by the time they come to surgery, only 30% have tumors that are amenable to surgical resection, curative resection. So at the time of presentation, 70% unfortunately have spread into areas where the tumor may not be accessible to cure, even in the best hands. And that very large percentage of the population then requires medical therapy and or radiation therapy to normalize the IGF-1s. But surgical debulking is the first step. So what are our goals of therapy? And as you see in this slide, I actually have decided to put reversal of clinical signs and symptoms as the #1 goal, because that really directly impacts patients' quality of life and their day-to-day experience. But in order to reverse the clinical signs and symptoms, we have to control growth hormone and IGF-1. We also want to preserve the rest of the pituitary function, and that is a particularly attainable goal with medical therapy, because in the process of surgery, sometimes extra damage is done to the surrounding function of the pituitary inadvertently by the surgeon in an attempt to try and remove the tumor. But once we have our therapies, they're very targeted. The acromegaly therapies that we've developed are really medications that work in the growth hormone IGF-1 pathway only to suppress the production of both growth hormone and IGF-1. So even though I showed in my initial slide all those multiple pathways in the pituitary, our treatments that are so valuable in 2020 are targeted purely to the growth hormone axis. And that enables us to preserve, to the best of our ability, the rest of the pituitary function with the medical therapies that we are able to use today. We also want to stabilize or reduce tumor size, which is a variable success with these medical therapies. So that's where surgery has an advantage over medicine, in that it's able to remove the bulk of the tumor. Whereas in medical therapies, there is some tumor shrinkage, but it's not a major endpoint in medical therapy. So we are able to maintain the size of the tumors. They don't continue to grow, and a large percentage do shrink somewhat, 25 to 50%, and some maybe a little bit more. But we unfortunately are not really able to melt away these tumors with the medical therapies that we have now. So the two modalities of treatment that do that would be surgery and radiotherapy. And that's why we use medical therapy often in combination with those two other therapies in order to reduce the bulk to the maximum of our ability, and then to suppress the secretion, which is really the major function of the medical therapies. So this list now on the screen are the major groups of medical therapies that are currently available today and FDA approved. So the first group are the dopamine agonists, Dostonex or Acromegaly. The second group, the somatostatin analogs, which include short-acting octreotide, long-acting sandostatin, LAR, lanreotide, somatulene, and pasriotide, Signifor, and then the growth hormone receptor antagonist, pegvisomant. And these three groups of drugs work in different areas of the growth hormone and IGF-1 pathway, and I'm going to show you that in the next couple of slides. So this timeline is quite interesting, and it shows you the development of these drugs since 1988. So just over 30 years ago was the development and launch of short-acting octreotide, which is administered 3 to 4 times a day. And it took 10 years till the advent of long-acting once a month sandostatin LAR. So this was a very happy day for patients and their physicians. 1998, I actually do remember the enormous celebration when it was approved. And so it took 10 years to develop a once a month injectable form, which really revolutionized the therapy for acromegaly. And then in 2003, pegvisomant was launched. 2007, lanreotide, somatulene, was launched. And the most recent of the injectables, pasriotide, was launched in 2014. So just to give you an idea of the time frame, and then we'll discuss a little bit how these agents work and how effective they are. So just to remind you again, growth hormone is made in the pituitary, travels to the liver, binds to receptors on the surface of the liver, and causes IGF-1 release from the liver. And it's really IGF-1 that has the majority of the both physiological and untoward effects, which we deal with. And the next couple of slides show hone down at a micro level and explain exactly how these medications work. So there we have the normal pituitary, which, as we've said, makes growth hormone, which travels to the liver and stimulates the liver to elaborate IGF-1 into the circulation. In patients who have benign growth hormone secreting tumors and acromegaly, there is excess growth hormone secreted from the pituitary, excess growth hormone traveling to the liver, which results in elevated IGF-1 released into the circulation. And the somatostatin analogs work, as do dopamine agonists. The oral dopamine agonists work by binding to somatostatin receptors on the surface of the tumor and, in fact, on the surrounding normal pituitary growth hormone secreting cells as well. So the somatostatin analogs actually mimic a person's native somatostatin. So in the control of growth hormone secretion in our bodies, there is an inhibitory hormone called somatostatin, which is a natural inhibitor of growth hormone secretion in the pituitary. And the pharmaceutical industry have developed drugs which are analogs of native somatostatin and work on the same receptors by inhibiting pituitary growth hormone secretion. So they bind to the same receptors that our natural somatostatin binds to, and these drugs then suppress pituitary growth hormone secretion, just as our natural somatostatin would, and there is therefore less growth hormone secreted by the pituitary. There's less growth hormone that then travels to the liver. If less growth hormone binds onto the surface of the liver, then there's less IGF-1 elaborated by the liver. And that's how somatostatin analogs suppress pituitary growth hormone secretion and lower and hopefully then normalize IGF-1 in patients that have excess secretion. So this slide shows you all the different currently FDA approved medications that are administered by injectables. And many of you on here today, I'm sure, have been or are currently on these varying different preparations. So how do these medications work? So the octreotide, which is the drug that suppresses the growth hormone, in the case of sandostatin LAR, is bound onto a microsphere. And these blue round balls are the microspheres that you can see have octreotide bound onto the surface of the sphere. And as the sphere degrades with time after injection and gets smaller and smaller, the octreotide, which is the active ingredient, is secreted into the blood, and the levels increase as the microsphere degrades. So it's an extremely smart depot preparation which degrades after it's been injected intramuscularly, and it just the microspheres degrade and release octreotide continually into the blood over the 28-day period of the activity of the shot. So you can see on this slide that the orange graph is the growth hormone levels, and the black graph is the sandostatin LAR levels, and you can see that the levels pretty much peak after 28 days, and then the downhill starts as the drug is no longer released from the microspheres into the body. And that's this. The pharmacokinetics demonstrated in this slide show you why we administer these shots every 28 days. This is lanreotide, which has got a total different physical property. It's a helix which unravels, and as it unravels, it releases the lanreotide into the circulation. And it also has a 28-day half-life and requires re-injection after that time period. As you can see, middle slide at the bottom, 28 days, the levels are maintained and then they fall off. So now moving to a completely different preparation, which we did mention on our list of medical therapies, and that is Somavert or pegvisomant. And Somavert, in the last couple of years, many more strengths were released, and we now have 5 different strengths of Somavert, and this gives us a huge amount of flexibility to administer it either on its own or in combination with the somatostatin analogs in a whole variety of different ways to really have patients get maximum benefit at the lowest possible cost. To show you how Somavert works, the same cartoon that we saw earlier, the top showing the pituitary secreting growth hormone, the excess growth hormone, the tumor secreting the growth hormone, the excess growth hormone traveling to the liver, causing excess IGF-1 production. Somavert or pegvisomant, however, does not bind onto the tumor as did the somatostatin analogs and in fact the dopamine agonists. Instead, it binds peripherally onto the surface of the liver, and it actually prevents the native growth hormone having access to its receptors on the liver. And when growth hormone can't bind to the liver, it's blocked by the pegvisomant. IGF-1 is not able to be secreted in that excess amount, and the levels fall to normal. So there are two, basically, if one thinks about it, there are 2 different levels in the growth hormone pathway that these drugs work. The first level is directly binding to the tumor itself in the pituitary, that's the somatostatin analogs. And the second level, where we have drugs that can intervene and help us lower the IGF-1, is directly peripherally on the surface of the liver. So we're able to block the growth hormone binding to the liver, and that stops more IGF-1 being elaborated, and that helps to lower IGF-1 levels. So let's look now and see how effective our therapies are. So this slide tries to point out the ease of administration of the different medications that we've discussed and point out some of the similarities and differences. So somatostatin analogs here on the extreme left are administered once monthly. LAR is an IM injection. Lanreotide is a deep subcutaneous injection. They're administered in the doctor's office, and the benefits are they're just once a month. The not so pleasant effects are that it requires a visit every month, although people are doing it more and more themselves. Lanreotide does have an indication for partner administration, but often it does require administration by a healthcare professional. Pegvisomant, on the other hand, in the center of the slide, is FDA approved to be administered daily, but actually we're using it often far less than daily, 2 or 3 times a week, and sometimes even just once a week, and that's extremely effective. And pegvisomant can be administered either by itself or in combination, and we'll discuss that in a little bit more detail as the talk unfolds. The other very convenient thing about pegvisomant is it's a subcutaneous injection, and it has the convenience of being able to be self-administered, which gives people way more independence. Moving over to cabergoline. Cabergoline is possibly the easiest of these 3 to be administered because it's a tablet. It can be, it's really FDA approved to be administered twice a week, but in acromegaly, we often administer it daily because we require high doses to get it to work in acromegaly. It was developed for the use in another pituitary tumor called prolactinoma, but it does work in patients with acromegaly if it's administered in higher doses than in prolactinoma patients. And if it's a tablet, it can obviously be self-swallowed. Oh gosh. Okay. Right. In terms of normalization of the IGF-1, how effective are these agents? So there are studies that have been published that suggest that somatostatin analogs are effective in as many as 70% of patients. However, careful evaluation of some of those earlier studies more recently have shown that although there is published data that it is effective in as high as 70% of patients, in actual fact, the realistic expectation is probably closer to 50%. So our working efficacy figures for somatostatin analogs in 2020, when we do very careful trials with the right inclusion and exclusion criteria, put it at more of 50% efficacy. Whereas pegvisomant is actually efficacious in terms of normalizing the IGF-1 in close to 100% of patients if one increases the dose high enough. And we'll discuss some of the other benefits and risks of all these agents as we proceed. But just in terms of efficacy, pegvisomant is magnificently efficacious, probably one of the best of all the agents available. However, the downside is the cost is very great. So we have figured some tricks in order to be able to include it in therapeutic algorithms where we can utilize the efficacy, and especially in combination, that cuts down the cost enormously. So we've learned to work with these agents to maximize the benefits of them and to reduce some of the risks, one of which is extremely high cost. Cabergoline, as you can see, is effective in a very low percentage of patients, and it's usually the patients that have a minimally elevated IGF-1. So patients that have IGF-1s just 100 or 200 units above the upper limit of the normal range are usually those that will be cured or normalized with cabergoline. The very high levels, 2 and 3 times the upper limit of normal, generally are not responsive to cabergoline. So it is an agent that we use, especially if levels are minimally elevated, and the major benefit is that it is oral. So let's look now a little bit at the side effects of these drugs, and I'm sure many of you are very familiar with these, so we'll just go through them quickly, mainly for completeness, seeing we're doing major comparisons here. So somatostatin analogs are associated with mainly GI side effects, abdominal cramps, diarrhea, gas, usually gallbladder sludge in more of the patients than frank gallstones themselves. Interesting about the GI side effects, they're often more prominent when people first start on somatostatin analogs, and with the passage of time, they seem to get less. They're also more frequent round about the time of the shot, and as patients move further and further away from the shot, generally the GI side effects get less. Pegvisomant is associated with headache and fatigue, and the concerning side effect is an elevation in liver enzymes, and this is something we need to monitor very carefully. The FDA in the label allows us to continue administering pegvisomant even if liver enzymes are elevated, provided that the liver enzyme elevation is less than 3 times the upper limit of normal. By the time it reaches 3 times the upper limit of normal, then we need to discontinue it, and unfortunately, future exposure is then limited as well. Another side effect is lipohypertrophy. Patients notice some lumps at the site of the pegvisomant injection, and they can even experience some atrophy of the skin as well. Acromegaly is associated with nausea, some abdominal cramps, headaches, and nasal congestion. And these side effects can be very bothersome, especially in the sorts of dosages we often need to see an effect in acromegaly. So it really is a very second-line therapy. Looking at the costs, which I'm sure everyone is aware are pretty staggering, the costs escalate as the dosage goes up. And in terms of somatostatin analogs, they're about 3.5. These are costs for sandostatin LAR, but the lanreotide costs are very similar. And the costs quoted are the average wholesale price, and these prices vary with the institution that is marketing them. So the point is that the somatostatin analogs are about $3,500 for the lowest dose, the average wholesale price, 20 milligrams a month. 20 milligrams a month, the mid-range of the dose, which is 90 of lanreotide, is about $4,500 a month, and the highest dose is about $6,500 to $7,000 a month. Astronomical costs. Pegvisomant costs $20 a milligram. At 10 milligrams a day, it's $205 a dose. 25 milligrams a day, $515. 30, $615. So these are really enormous costs, and it behooves us to try and take advantage of the benefits of these drugs and reduce the cost. And the major way we are able to do that is to reduce the frequency of administration, both in terms of the number of times it's administered, as well as the actual quantity that we're administering. And we've been very successful. We've actually just published, and I'm going to show you that publication towards the end of the discussion, a study which has very effectively, and I think many people from the group have participated in the study, but we are very happy to say that we really did show that we are able to combine these agents both by administering them less frequently and at lower dosages, and still maintain the same efficacy, but obviously at a much lower cost. So I think this is going to be very important moving forward, and hopefully when this becomes, an accepted practice, will greatly reduce the cost of therapy. And we're excited about this, this novel finding, which I think is going to really greatly impact availability of these drugs, which really are pretty spectacular in terms of disease control when combined. Acromegaly, even though it's a second-line medication, is not a cheap drug either. 7 tablets a week clocks in at $1,000. So there's really no inexpensive way out here other than being savvy about using these drugs in the smallest possible dosages. So what's new? Pasriotide the oral octreotide, which was just approved 2 weeks ago, and combination therapy, which we've briefly discussed on, but we're going to discuss in more detail a little later. So let's look a little bit about pasriatide, which has been FDA approved since 2014 and is in a very active clinical use all over the world. Just to explain to you how pasriatide differs from lanreotide and sandostatin LAR, and I'm just going to briefly go over it as a technical point, but maybe of interest to people who have changed from these different medications from one to the other. And the basic difference is the number of somatostatin receptors on the pituitary that these somatostatin analogs bind to. So there are 5 different somatostatin receptors on the pituitary. Some of the subtypes are associated with cell growth. Some of the receptor subtypes are associated with signaling that results in a growth hormone secretion. And some of the receptors are associated with other functions. But we're going to focus today just on the subtypes that are associated with cell growth, because that affects tumor size, and with the receptors that are associated with secretion of growth hormone, because that controls the hormonal secretion of the tumors. So native somatostatin binds to these different receptor subtypes, and the drugs that we have developed also bind to these receptor subtypes. So subtype 2 is the somatostatin receptor that's mainly involved in growth hormone secretion, and subtype 4 and 3, and to a smaller extent 1, are involved in tissue integrity. So if you have an agent that binds mainly to 2, and that's what sandostatin LAR and lanreotide do, they bind very specifically to subtype 2 and a little bit to subtype 5, then the major effect of those drugs is just going to be through whatever those receptors signal. Pasriatide, on the other hand, binds actually to all the different receptor subtypes, and the pharmacokinetic goals for pasriatide were that if it bound to more receptor subtypes, it would be more effective in, and it binds equally strongly to all the subtypes, it would be more effective in controlling tumor volume and may be more powerful in terms of suppressing growth hormone secretion. So the cartoon on the bottom of the slide shows you lanreotide and octreotide, which bind mainly to subtype 2 in black, and pasriatide in red, which binds to all the different receptor subtypes, a little bit actually to subtype 4 as well. And then you can see that somatostatin in the brownish color binds very, very much more strongly than either lanreotide group or pasriatide to all the different receptor subtypes. So that's how we've got specificity with these different drugs. Pasriatide is a subcutaneous injection, and it is administered twice a day. So it's a twice a day subcutaneous injection. In terms of IGF normalization, it is 20% more effective. The major drawback of pasriatide is that it really is very effective in provoking hyperglycemia. So because of its binding to all these somatostatin receptors, it binds actually to somatostatin receptors in the pancreas and various other parts of the body as well. And as a result of that, there is a very high incidence of hyperglycemia. You can see 30% hyperglycemia in pasriatide versus 8% for the first generation, the octreotide, LAR, and lanreotide. So we are getting 20% more effectivity in terms of IGF-1 normalization, but at the same time, we're incurring a very high incidence of hyperglycemia, which needs to be treated with additional medication and monitoring. You know, I'm sorry to say our neighborhood is having intermittent internet problems. I actually had to go to my neighbor because my internet was down completely. And I'm having a lot of trouble, and I see we're having intermittent problems here too. So I'm so sorry about this poor transmission. And it's totally not advancing at all now.
So so Dr. Bonner, the little arrow, the arrows won't.
No, I'm trying like crazy to do that. I'm wondering if the internet, you know, I've seen that the internet is coming and going, but I've been able to dodge it. But I don't know why this. Oh, there we go. It's intermittent. Okay, so let's move now that we've got it. So let's talk now a little about the latest tool we have, which is a very exciting new release, oral somatostatin analog. So this was just released 2 weeks ago. It's been FDA approved, and it's in the process of being launched and marketed, and we've been in touch with the company to figure the pathway to make this available. But it is available, and we're starting to prescribe it and use it. So this is something that we've all been waiting for 30 years, and I think it's a very exciting new development. So let's just discuss a little bit how it works. The preparation is called MyCapsa, and it is an oral preparation, and it is administered twice a day, 1 tablet twice a day. It does need to be taken in relation to meals, and I'm going to explain to you why that is. And that's because it makes use of a technology called a total permeability enhancer. So patients swallow the capsule. It goes into their small intestine, which is the food pipe that is connected to with the food pipe that travels all the way through the body. And once it gets into the intestine, the intestine is very well sealed, because if it leaked, all the valuable food and medications, including the bacteria, would just leak out into the gut cavity. At the same time, we do need to have the wall of the intestine opened intermittently to let food and drugs pass from the wall of the intestine into the bloodstream. And this shows you, we'll have to do it on this. I do have it magnified in the next slide, but it looks like we're stuck again. Gosh, this is so maddening. So what the total permeability enhancer does is it has the ability to loosen these, we call them gap junctions. So they keep the cells of the intestine very closely sealed. When these junctions release, then the pathway from the intestine to the bloodstream opens up, and agents that are in the intestine are able to go through the wall of the intestine and get through the blood. So the MyCapsa has TPE, total permeability enhancer, which enhances the permeability of the intestine wall, and the drug is then able to move into the blood, travel to the liver, and control the growth hormone secretion when it reaches the pituitary. So it's a very smart mechanism. Just going to see. I don't know, Jill, I'm not able to. It's a very smart. There we go. A very smart mechanism. Here it's enlarged for loosening the intestinal wall and allowing absorption of the drug. So we're just waiting to use it, and the efficacy data look absolutely excellent. The label does say that it needs to be administered to people that are already on somatostatin analogs, either pasireotide, lanreotide, or sandostatin LAR. But once it's FDA approved, we will be able to administer it however we choose. But the label does say that patients have to be prior on a somatostatin analog, but I'm sure that that is something which might not be followed to the letter of the law. So let's move now to quality of life, which I think is a very important topic. And how do we define quality of life? So quality of life is how a person feels, functions, and responds in their daily life. It's a subjective sense of wellness. And there are all kinds of factors that contribute to quality of life. There are physical factors like the presence of symptoms. There are medications which have side effects that make people feel unwell, that have methods of administration that might be painful and unpleasant, like injections, which have to be given very often. And another enormous fact is the cost. So that can certainly make people feel unwell, having to deal with it, afford it, and be sure that they stay funded in order to afford these very expensive medications. So those are just some of the factors that are important. Obviously, one has less symptoms when we have tighter control, and that's why we really are working so hard to try and ensure that we have not just lowered IGF-1 levels, but actually normal IGF-1 levels. Then there are all kinds of psychosocial factors that also affect quality of life. They're people's goals, they're their standards, their expectations, their concerns, various different life events. And a factor that's actually very much we've become aware of just in the last couple of years is that endocrine control does not equal normalization of quality of life. And by that, I mean that there is a very high percentage of patients that despite attaining normalization of their IGF-1s, do not attain a normal quality of life. And that's for a number of reasons, and we're going to discuss those on the next series of slides. So we know that reduced quality of life correlates with disease activity primarily, because the more active the disease is, the more symptoms patients have, and the more quality of life reduction they then experience. We also have become aware through the studies listed here that there are certain symptoms and factors in people's histories and treatment paradigms that really reduce quality of life more than others. Musculoskeletal pain is one, headache is another, prior radiation therapy, older ages, female gender, longer disease duration, coexisting diabetes mellitus, being overweight, and actually becoming growth hormone deficient after the treatment of acromegaly have been evaluated to be specific factors that are particularly involved with reduced quality of life. Those are symptoms and issues. I mean, obviously we can't change much about older age, disease duration, but one should just be aware that whatever can be reversed should be in terms of normalizing the IGF-1 and attaining control of disease activity. And musculoskeletal pain, headache, of coexisting diabetes, weight loss, those are symptoms which we need to work on in a very diligent fashion, because they're particularly pivotal in reducing quality of life. And the agents that we've discussed are primary in terms of controlling the IGF-1, and then we need to invoke the use of other agents and therapies to control those different symptoms, because they're particularly bothersome and troubling. So I just want to mention this paper of Christian Strasburger's 4 years ago, which was the first reported patient-reported outcome, which really drew our attention to the fact that greater than 70% of patients in this cohort of 195, half of which were controlled, but half of which were not controlled, greater than 70% reported symptoms despite treatment. That is, a very staggering figure. I mean, it's pretty obvious in the people that are uncontrolled. One might assume that the symptoms would persist. But in those that were controlled, we would hope that, there would be eradication of symptoms. However, there is persistence of some comorbidities, unfortunately a lot of joint problems, that does persist because there has been permanent joint destruction, does persist despite normalization of the IGF-1, and those factors should be very aggressively investigated and taken care of, either with a medication to relieve pain or surgical intervention to replace damaged joints. And we need to be aggressive in taking care of musculoskeletal factors that can be reversed, either through normalization of the IGF-1 or orthopedic interventions that can stabilize joints and relieve pain. 52% of patients had breakthrough symptoms, also a staggeringly high figure, 52%. Breakthrough symptoms are, for those that are not aware of this, are patients who at 3 weeks into their 4-week somatostatin analog cycle get breakthrough of headache, fatigue, joint symptoms. So although these drugs are really pharmacokinetically engineered to work for 4 weeks, some patients already start experiencing symptoms 3 weeks into the cycle, and we have some tricks as to how to deal with that. But that's something that's now, for the first time, characterized in this paper, the high percentage of patients that become symptomatic earlier in the cycle than we really were aware they were becoming symptomatic. And one solution to this may be to take the shot a week earlier. Another solution might be to use combination therapy, and that's what we've done in our study. And the third thing might be to give some short-acting octreotide at that time in order to alleviate the symptoms until it's time for the next shot, if they're not able to get the shot more frequently. And then there are junction-related symptoms like pain at the injection site, nodules, swelling at the injection site, bruising, scar tissue, and inflammation. So these are all factors which directly affect quality of life. And then this paper, which has just been published in Pituitary, was a really, I thought, magnificent study that showed the discordance between the outcomes reported by patients and their providers. So this study interviewed the doctors taking care of patients, and then they had the patients fill out quality of life questionnaires, and they found a very poor agreement between the medical providers and the patients on the frequency, the severity, and the pattern of symptoms, as well as the severity on the injection site reactions. So the doctors definitely were aware that their patients were symptomatic, but they were not very in tune with how frequent the symptoms were, how severe they were, and how severe the injection site reactions were. So I think this is a very important paper that really needs to be extensively circulated in the medical community to increase awareness of this shortfall in one of the basic goals of therapy, which are outlined right at the beginning of the talk. So drugs in the pipeline, there are numerous drugs in the pipeline, including, and some patients on this webinar may in fact be involved in some of these studies. So there is an oral selective SS2 analog being trialed by a company called Cronetics, and it's hoping that this agent will have more potent suppression of the growth hormone axis because of the way it's been engineered, and also it has the advantage of being oral. Then a company called Ionis has a antisense drug which actually blocks the growth hormone receptor, and that's how it blocks growth hormone action at the liver, and it's a growth hormone receptor blocker, so it works sort of at the same stage as pegvisomant. So that is another useful addition to our armamentarium if this is found to be as effective as they think it will. Then there is a subcutaneous depot-octreotide, so it can be self-administered subcutaneously every either 2 to 4 weeks, being trialed by a company called Camurus, and it's in phase 2. It's also going to be launched as a subcutaneous pre-filled syringe when it comes to that. And then a really fascinating preparation, which we heard about a couple of years ago, but we haven't heard anything more recently, so I don't even know where the research is with that, is DP1038, which is a fascinating intranasal preparation of short-acting octreotide, and it is intranasal, so it avoids tablets, it avoids injections. And as I say, we haven't heard anything of this recently, but there were some original studies which looked very promising. So hopefully they are hopefully they're working on moving this to market. I was pretty fascinated by it and have been watching out for some progress. So in the interest of time, I'm actually going to end there because it's very late and I really did want to leave some time for some questions, and I'm certainly happy to stay on if people have questions and we're over time.
So why don't, if anyone has any questions, do you want to put them in the chat box, or Jenny, let's see.
So, we've got the, yeah, so, this internet connection keeps coming and going. I don't know if you were able to pick that up. So, Jill, if you can watch out and listen, that'll just help us as much as possible.
Jenny, did you have a question that you wanted to ask, or?
Nope.
No? Okay.
No, sorry, no questions.
Okay. Glad to see you down under.
Good to see you too.
Okay, I'm going to mute you back.
Okay.
Okay. So actually, Dr. Bonert, we have patients literally from all over the world on this call.
Oh, wow.
Jenny was from Australia.
Oh, wow.
Yeah. Does anyone, if you have any questions that you want, hold on. Someone just said, thank you so much for this presentation. Often within our groups, people don't understand how these medicines work. And I can't tell you how much I appreciate you going over how each of them work, because I truly believe that, it's up to patients to understand in order to make the best choices for them.
Right.
Here's one. Hello, you mentioned that surgery and radiation is the best way to get rid of the tumor, but do surgery, medication, and radiation, would it be better to change our treatment plan?
So what I really meant to say, and perhaps I didn't phrase it correctly, but what I meant to say was that surgery and radiation is the best method to reduce the tumor bulk. So the medicines don't shrink and melt away the tumor as effectively as surgery and radiation. And we do try and surgerize everybody, debulk them as the first step. So wherever we're able to, patients initially get a surgical debulking where the surgeon removes as much of the tumor as is physically possible without causing too much damage to surrounding structures of the surrounding pituitary. So we do enlist tumor reduction via surgery rather than via medicine, because medicine is not that effective in shrinking and melting away the tumors. It does shrink the tumors to some degree, but it wouldn't melt them away completely. Whereas with surgery, you have a much greater chance of reducing the tumor bulk, and radiation over time also reduces the tumor bulk. With surgery, it's more restricted, but in about 50% of patients, there's a 25% tumor shrinkage, and maybe 10 or 15% have more than 25% tumor shrinkage. But tumor shrinkage is not one of the major benefits of medication. We do know that the somatostatin analogs prevent the tumor from growing, and in a percentage of patients, they do shrink the tumors a percentage, but they're not going to melt the tumors away. Whereas with surgery, you have the potential to remove as much of the tissue as is accessible by that clear.
So here is a good one. I hope that we didn't just lose you, Dr. Bonert. Can efficacy of these medications change over time? Can it work for a few years and then can the efficacy decline?
Oh, that is an absolutely excellent question. So I didn't mention it. I will just tell you that the efficacy does not decline with the somatostatin analogs. I don't know if that data is out there yet for pegvisomant, but it is out there for the somatostatin analogs, and patients do not become tolerant to the somatostatin analogs. So with time, the efficacy continues at the same level as it always was. Patients do not become tolerant. What a good question.
So can I chime in on that? So when a patient increases their dose over time, is it just because the patient's condition is getting worse then, or and they need a higher dose to help control the disease?
So that might be somebody who was controlled and then is not controlled. That would be a situation, or it may be someone who may have been just over the top of the range or at the upper limit of the range, and there may be a decision made to try and lower the level to mid-normal. So my therapeutic goals are always to try and get patients into the mid-normal range, because levels do bounce around, and if it's right at the top of the normal range, then sometimes, because of the pulsatile nature of hormonal secretion, it may go over the top. So my therapeutic goal is to get people in the mid-normal range in order to ensure that they really are safely in the range round the clock. And for patients that have been at the upper limit of normal or maybe just over the top, there is sometimes a need to increase the dose in order to bump them down.
Okay, here's another. I was wondering what damage...
There are a very small... Just add on there that there are some very aggressive tumors that maybe do stay controlled for a while, and then because of the aggressive nature of the tumor, they may go out of control and grow. So it could be just an aggressive biological pattern, which is not due to the patient's tolerance of the medication. It's just a tumor type that has a very aggressive growth pattern. And we definitely do see patients that have those kinds of tumors. So that may be a reason why people may need to go up, because the tumor may just be growing more aggressively than it was a year, 2 or 3 years ago.
Okay. I was wondering what damage is done to our heart without treatment with acromegaly, and what damage is done with treatment, if any damage. Does it pause the damage? Does treatment typically pause the damage?
Right. So that's interesting. So the somatostatin analogs do have bradycardia, which is a slow heart rate, as one of the side effects. It's very rare, and it often is asymptomatic. But if it is symptomatic, then that's a problem. The other way that so that's in terms of the medication. The only direct risk to the heart that I'm aware of the somatostatin analogs is bradycardia, and people who have very slow hearts, could be very fatigued and could faint, and it's not a good thing. It's to have a slow heartbeat. You need the heart to pump at appropriate pace in order to fuel the body, and so that's a direct deleterious effect of the somatostatin analogs. In terms of acromegaly itself, untreated, cardiac effects are serious, and they do contribute significantly if the IGF isn't controlled, and then the deleterious effects of growth hormone are not taken care of. So the major problem is that patients with acromegaly, because of the growth hormone, have hypertension, and if hypertension high blood pressure is not treated, that can result in enlargement of the heart, which can with time become permanent, because the way the heart works to overcome the high blood pressure is that there's muscle hypertrophy, which can be, which will not be reversed even after the blood pressure is controlled. So it's really a response to the hypertension that causes an enlargement of the heart. There is some just swelling of all soft tissues, and that does remit with treatment and normalization of the blood pressure. And for a large, in the earlier stages of heart enlargement, there can be reversal of the enlargement with treatment of the hypertension. And one of the ways you could treat the hypertension would obviously be start by normalizing the IGF-1 and the growth hormone. But secondarily, if that doesn't normalize the blood pressure, people need to take antihypertensives independently. So very long-standing hypertension with cardiac hypertrophy, the heart enlargement may not be reversed. But if it's caught early, there often is reversal of the heart enlargement with normalization of heart size.
So this next question, I think they might be asking it because they know that you've done some studies with Somavert. They said if someone is taking 60 grams of Somavert, did you say they might have the same outcome taking a lower dose?
Right. So we ran out of time, and I really didn't have a chance to discuss our study. So we just looked at that. We just looked at that now. So in our study, we looked. So the current guidelines have an elevation in how we add therapies in the treatment algorithm. So we've had a number of consensus panels where experts have come together and tried to decide the best way to advise practicing endocrinologists all over the world, because these medications are available there, as to how to best administer these medications. The recommended pathway, and not everybody follows that, is to start with a somatostatin analog, especially if there is a significant tumor remnant, and then to increase the dose of the somatostatin analog to the maximum dose to see if one can attain normalization of the IGF-1. If at maximum doses of somatostatin analog, be it lanreotide, sandostatin LAR, pasreotide, whichever of the somatostatin analogs are being used, if when the dose is maximized, the patient still does not have normalization of IGF-1, the next recommendation is either to stop the somatostatin analog and just use pegvisomant alone, which would then require daily pegvisomant, although if patients have a large tumor remnant, that's not recommended, because if you recall, we had mentioned that the somatostatin analogs are very effective in controlling tumor volume, and that's why we like to have some somatostatin analog on board. However, there are people who might just have a small remnant, and they may not want to, or have insurance that would cover 2 agents, and they may just want to go on pegvisomant monotherapy, and then probably daily pegvisomant. So that would be 10 milligrams a day would be a way to start. So you'd get 70 milligrams a day as a start. And then what one could do might be to cut back to less than daily, because in our study we've shown that one definitely can use pegvisomant in less than daily doses. And it wasn't just our study. There are several other published studies that have shown that pegvisomant can be administered 2 or 3 times a week and can still be effective in normalizing the IGF-1. So back to the algorithm, assuming patients don't get control on the maximum dose of somatostatin analogs, either one can switch to pure pegvisomant alone, which is pegvisomant monotherapy, or pegvisomant can be added to the maximum dose of somatostatin analogs. And the way that works is that if you've already got maximum dose of somatostatin analog on board, then you've lowered your IGF-1 to a large degree already by the somatostatin analog. And then one might be able to add pegvisomant in a lesser frequency as well as a lower dose, because you've already had some of the work done by the maximum dose of the somatostatin analog. So one might add pegvisomant twice or 3 times a week, and that extra pegvisomant at a lower frequency and lower dosage could then, in combination with a somatostatin analog, be very effective in finally normalizing the IGF-1. So that's how that plays out. So it's very unlikely that in combination one would need a dose as high as 60 milligrams, but with daily pegvisomant, there could be people that would be on as high a dose as 60 milligrams. And at $20 a milligram, you can do the math and figure out how exorbitant that is, and not likely to get too much of a heads up from the insurance, unless one does huge, you advocate hugely. And we have done that. I do actually have 2 people that are on 60 milligrams a day, and we did have to do a fair amount of advocating with the insurance to have them funded. But that was pretty much the only way these people were able to be controlled. And that was what I meant when I said, if one escalates the dose high enough, almost 100% of patients can get control if one has the ability to use these massive doses on a daily basis of pegvisomant. That's why those figures said 97% for pegvisomant control. Those were the figures from the original registration studies in 2000. I was actually part of that study, and we didn't have anybody on such a high dose. The dose was like 35 to 40 milligrams was the maximum daily dose that was used. But now we really use pegvisomant in less than daily dosing very effectively, especially in combination. And what I did in my study was and the study is still ongoing, so if people are interested in participating, I'd be delighted to consider them. We also have e-consent, so we are able to now consent people virtually with the travel restrictions that people have, and we can even do video visits to include people and to follow them. So if people are interested in joining the study, we'd be delighted to consider you. Actually, we're taking controlled people, uncontrolled people, people who are on any preparation going in. And the first 6 months is a combination therapy phase, and the second 6 months is a pegvisomant monotherapy phase. So if anyone is interested in trying pegvisomant, if they haven't already, here would be an opportunity. All the pegvisomant and the lab tests are free of charge as part of the study. Patients do need to take a somatostatin analog as part of their standard of care, but all the rest is provided free of the study. So we've just completed the first part of the study, the combination therapy phase, but we still need some more subjects in both phases, so it's still open. So what we tried to do in the study was use lower doses of both somatostatin analogs and pegvisomant. So rather than maximize people out on a somatostatin analog, we have 2 arms of our study that has people on low dose somatostatin analog, either sandostatin LAR or lanreotide. And then to that, one group gets weekly pegvisomant and one group gets daily pegvisomant. And then there's a third group that stays on their high dose somatostatin analog, and we give them once a week pegvisomant. And we were just interested in seeing how playing around with the frequency as well as the dosage of these agents was able to control it. And we have really excellent that just actually came out this weekend in GCNM, and we showed that it's very effective to use low dose somatostatin analog and once a week pegvisomant. You have the same efficacy as high dose somatostatin analog and daily pegvisomant. So out of all our 3 combinations, low dose somatostatin analog and once a week pegvisomant was actually the most efficacious. It was as effective as the other 2, which the one used daily pegvisomant and the other arm used high dose somatostatin analogs and once a week pegvisomant. But interestingly, the low dose somatostatin analog and once a week pegvisomant was the most effective, and it's obviously the cheapest. So we're very excited. We've also done quality of life questionnaires. We haven't even started to look at that data yet, but that we're in the process of, doing now. And we're very excited with this data. I think it's going to enable us to use these excellent drugs in a way more cost-effective way, which will bring relief to patients, as well as, a cost-effective way of using drugs we know are effective and can be combined to really have the best patient outcomes. So I hope that's answered the question.
Yeah, and there's just a few more questions, and I think I'm going to combine some for your time.
And Jill, I'm very open. It's Sunday.
Yeah.
We did start late, and we had all these internet problems. So don't cut people off. I'm happy to carry on.
Someone asked, do some patients do better on octreotide, sandostatin LAR, or lanreotide? Is it worth switching if one doesn't seem?
Excellent question. So the efficacy is identical. We really do not believe that the one is more effective than the other. But interestingly, I have tolerate one better than the other. So I haven't seen much of a difference in efficacy. In other words, the IGF normalization is very much equivalent. But sometimes people do have less side effects on the one than the other. So if they want to switch, if the people are interested in switching because they don't like the side effects, I think that's worth trying. But I don't think there's much difference in the efficacy, unless the injection is not being given right, because lanreotide is a deep subcutaneous shot and sandostatin is an intramuscular shot. So the person that is administering it needs to put it in the right space in order for it to be the most effective. So I could envision that maybe one seems more effective than the other if it hasn't been injected into the correct space and may not be absorbed appropriately. So that's one way that there may be a difference, inappropriate or incorrect administration, rather than a difference in efficacy. Administered correctly, they are head-to-head the efficacy. But if they're not administered right, people may not have proper absorption, and then it might look as though it's not as effective. But I definitely have noticed differences in the tolerance in terms of side effects between the two.
And I think this is, I'm going to combine this question and so they're asking about the new oral Mycapssa drug.
Right.
They want to know regarding it if it will be used in younger patients. Do you see it being available for patients under 18?
Everybody. I think it's FDA approved for everyone. Yes.
And I know some of the answers to some of these questions. How much before and after eating does it have to be taken? If you don't know, I can answer those.
Right. So I think you have to have it an hour before and you have to wait 2 hours, right?
So it has to be taken on an empty stomach. Correct. You are correct. If someone has issues such as celiac disease, does that influences the small intestine? Do you think that will influence the medication? I do know that proton pump inhibitors.
Right.
You can't take proton pump inhibitors at the same time.
Right. That is true, proton pump inhibitors. Gosh, that's an interesting question about celiac. That's a very interesting, I'll have to look into that. I don't know the answer. I'm just trying to think it through.
So what I can do, I can reach out to the company and get an answer and get back to this person. I'm happy to do that.
That's a very important question. I would think not, but because all it does is just very transiently opens the gap junctions, and the celiac disease does not cause a leaky gut, so I think it should be just fine. Celiac is more an inflammatory, but that's an excellent question. We should definitely look into it.
Are there any endocrinologists in Canada taking part of the study that you're doing regarding pegvisomant?
No, I'm the only person doing it, even in the US. So what I've just reached out to colleagues all over to send me patients, and we ship the pegvisomant. So that would be the problem with Canada. Let me look and see if that pharmacy would ship to Canada. If they would, I'd be willing to take that person. But that would be the major problem. If we can't, if the investigational pharmacy doesn't ship to Canada, we wouldn't be able to enroll someone.
Okay. And this is the final question that we're going to take, you guys. Type 2 diabetes is an outcome for some people using Sandostatin LAR, since it increases blood sugar.
Sure.
Although pills can stabilize blood sugar, is it harmful over the long term? And is there an alternative medication for those that have this reaction to Sandostatin?
So interestingly, pegvisomant does the exact opposite. Pegvisomant actually lowers the blood sugar. So that is, there's a direct agent in the space that has the other effect. Often, as people controlled, their blood sugar does become controlled just from less hormone around. Pegvisomant is the answer. Otherwise, one needs to take oral hypoglycemic agents. But if pegvisomant is an option, that would be a very effective medication, or in combination.
Well, I want to thank you, Dr. Bonert, for being so generous with your time and really helping to educate our patients.
Sure. I'm happy to have the opportunity. I think it's a real partnership, and if people don't understand what they're dealing with, it just makes it harder. This is lifelong therapy for many people, so the more one understands about it, I think the easier it is to be engaged in, being compliant. And as I said, it's a partnership. We can prescribe it, but patients have to be compliant in order for us to do the job. So I'm always happy to explain to people what we're trying to do, how we're trying to do it, and the tools that we have in our armamentarium to do that, so that we can partner together to get the best outcomes.
And there's all sorts of patients that are saying thank you. Thank you for that. This was a great educational session for them, and like I said, we truly do appreciate you.
Great. I've worked in the space for a very long time, and I really, I was once at a meeting when I first joined this field where there was someone who said, for those of us who've been here more than 10 years, we eat, sleep, dream growth hormone, and I at that point didn't even know what they were talking about, and I thought, what is this? And I will say that over the years I've actually come to join that club and that's much what I do. When you're involved in lifelong chronic disorders, it becomes like a part of, just a part of daily life. There almost isn't a day I don't treat someone with acromegaly in some form or fashion, even if it's just an email, a medication refill. So it's something, even though it's a rare disorder, that's constantly a part of my practice. So I'm very invested, and I thank you, Jill, for inviting me. And it's I'm always happy to do things with your community. I've met several people who've participated in my study, and as we were saying earlier, it's just an awesome bunch of really remarkable people. So anytime I can be of help, we're at our pituitary center at Cedars is a resource. Wherever we can help, please don't hesitate. We're happy to guide and help wherever we can. And as I said, anybody who's interested in participating in the study, I'll be happy to screen. That you could reach out to Jill, and she could just forward your information to me, and we'll reach out and chat and see how we can pull it together.
Yeah, absolutely. Email me or message me, and I will do an email introduction to Dr. Bonert, and you can get it done. So once again, our next talk, I'm actually in talks with the pain specialist, but he's based out of Florida right now. And as you know, he's in South Florida. And I'm not certain about if he'll be able to do the next talk or not, but if not, we will line someone else up. And, you know, I hope that you're enjoying our series and that you're getting something from it. And anyway, I wish you all a happy week. And thank you again, Dr. Bonert.
You're very welcome. Stay well. Be safe.
You too.
Bye-bye.